Hello, everybody. We are here from Sydney, the APHRS, Asian Pacific Heart Rhythm Society, and I'm here together with Melanie Gunawardene and Elad Anter. Hi, Melanie. Hi, Elad.
Hi.
So we will talk today about pulsed field ablation, actually a conceptually different approach compared to the thermal ablation procedures, compared to radiofrequency and cryo, which is mainly based on electroporation. And well, we can of course imagine that this new technique also confronts us with a lot of new challenges. So Melanie, if we think now about first do procedures for the treatment of atrial fibrillation, so what do you think, in how far did now everything change since we have pulsed field ablation compared to the thermal ablation approaches?
First of all, good morning, Dominik. Thank you very much for having us. It's a really good question. So all the studies that have been done, mostly the IDE studies, they looked at pulmonary vein isolation with pulsed field ablation, and it has been shown to be very efficient and safe. In real world, however, we saw that there's also other things going on with PFA because it's so much easier to ablate in a quick fashion, so that we see that targets beyond the pulmonary veins have been quickly targeted by physicians, and we see a lot of people also performing posterior wall isolations in real world data. But from the clinical and scientific side of the studies, it has been mostly pulmonary vein isolation that showed to be fast, efficient and safe.
This actually means even now in the era of pulsed field ablation, the first step for a first do procedure is still pulmonary vein isolation and actually not additional targets. Or what are your thoughts there?
Yeah, that is correct. From the data that we're having, there's trials ongoing that are investigating. And I think also Elad showed a study where physicians were supposed to do BVI, but they did a little bit more than that. So this just shows that with this technology that we're now having, where it's so much easier to create lines than before that era, we are also tending to do more. But the data is not there yet. So for now, pulmonary vein isolation is the way to go, especially in paroxysmal AF. For persistent AF, I'm sure we can argue about this.
Yes, but this of course then is the scenario of a first do procedure, right? But of course we are ablating more and more. The more we ablate, the more redo procedure we might actually create. And the substrate of a redo procedure is of course really, really different compared to a first do procedure. So in the era of PFA, Elad, do we still need mapping? Do we need bigger catheters, faster catheters? So what do you think is actually really needed for redo procedures when it comes to PFA?
Hi, Dominik. Hi, Melanie. Great to be here. It's a tough question because we don't have the science to answer it, right? I think PFA was born to improve safety and probably efficiency, and it's doing this very well. So there's no doubt for first-timers, PFA makes sense, right? For redos, what else are we doing apart from re-isolating the veins with confidence that this intervention will actually lead to improved outcome? I don't think there is any. So the goal is to re-isolate the vein, and all the other lines we do, although may have merit, haven't been proven to have merit yet. Now, that said, I think most physicians, including myself, will feel more comfortable to get some electroanatomical mapping to understand if there is a gap. Sometimes with low resolution mapping tools, you can't even tell if there is a gap and where is the gap. So to identify the gap, re-isolate the pulmonary veins, and then look for other things, posterior wall isolation, other lines, target other organized rhythms. But this is where it's starting to be a little bit dangerous in some way, right? Because we are going to ablate more and more, and the relationship between the amount of ablation and what Melanie mentioned or will mention soon about potential complications. So this relationship to the added benefit is unknown. So I think the PFA has done wonders, positive things for this field as far as patient safety and ability to take care of more patients. But I think now we kind of need to turn our attention and focus to dedicated studies that would look on additional lesion sets with PFA, and probably with focal catheters that can allow you to make designed lines with durability.
Yes. Indeed. So I think there, of course, still a lot of research needed, particularly also about which lesion set actually needs or should be performed under which conditions. And every lesion set, of course, also has its own set of complications, right? So when we actually think about the thermal energy sources, for example, everybody is always afraid about the esophageal fistula, about the phrenic nerve pulsary, about steam pops. And now the complications of tomorrow, Melanie. What are the complications of tomorrow when it actually comes to pulsed field ablation?
Yeah, thank you. Yeah, there's definitely a shift, and I think we have to divide complications into two categories. There's one that is associated with catheter ablation per se, that we will probably never get completely rid of, but we can improve safety, talking about tamponades, strokes, the sheets we're working with, flushing, more maybe imaging or guidance in those technologies. And then we have energy-specific complications, and that's where we see the shift right now. So we're moving away from problems with the esophagus or the phrenic nerve, but now we have to deal with coronary spasms, vagal responses, and with hemolysis. So there's new things. Are they always clinically relevant? I'm not sure we have enough data to support all of this. I think it's good that we're looking into it, we're investigating it. A lot of studies are currently published. Also, there's going to be a late breaker tomorrow about coronary spasms here. So I'm really looking forward to hearing more about this. But I think we have to have our eyes open and take this seriously, because what we're doing to our patients now, and especially with adding more ablation to the procedure, we have to be aware that we don't really know the long-term consequences of our patients yet.
Yes, I agree, right? So probably also in the future we might need to monitor all of those complications during and after the procedure differently than we did it until now, right? So probably a temp probe doesn't help too much in this almost non-thermal approach, right? But maybe it's actually just another lab test in the next morning to look at hemolysis or other things, right?
Yeah, I think so. For the hemolysis, I think that is something. Okay, we know it's happening. Red blood cells are being crushed by the electrical field, and we can add fluids and we can monitor the kidney function. So I think this is something that we can kind of manage in a routine clinical setting. About the spasms, it's a bit more complicated, because first it raises the question, can we even move forward in this field with the technologies we're having right now? Because we are all eager to target the ventricle, right? We want to create deeper lesions, more continuous lines, transmural and durable ones. And I don't know, with the devices that we're having right now, can we actually move forward? So this is a little bit the moment where I'm first like, there's a dip in the hype for me, right? Like I'm like, I thought this is what we can achieve, but now I'm questioning this. So we have to see, can we, with other waveforms and catheters, can we overcome this? Because also we do not know the long-term consequences, and spasms are not, like, they're set to be mostly subclinical. They can be prevented with nitro, but it's not always like this. Not every spasm can be prevented, and they're not all subclinical. And to have a patient in ventricular fibrillation or with ST elevations, hemodynamically unstable, in an EP lab setting where we're not in the coronary angiogram lab, it's just a whole different story. And this is something that we need to be aware of.
Indeed. And then, of course, also the long-term consequences, right? An acute spasm might be transient, but we don't actually know what happens after a couple of weeks, months, years. This is, of course, also still something which we need to study. Elad, so now we have PFA. PFA might be maybe implemented at some time point also in mapping platforms, might actually create point-by-point catheters and other things. So what do you think? Where are we going? So when we actually would sit here together again in about 5 years, what would we talk about?
I think PFA has created a revolution in the sense that we can take care of patients more rapidly, and we can take care of more patients. But in 5 years from now, my guess is that we're going to meet the same challenges we had, but without so many complications that we had before PFA started, meaning that the outcomes in my mind are not going to be better. I still think that, if you are going to put loop recorders, I know exactly what the recurrence rate is, you're probably going to look at 70% for paroxysmal at 1 year and less in persistent. And then we'll start to rethink again on the same problem that we put on pause 5 years ago. So I do think that we're going to go back to, I'm not sure point-by-point ablation, but to more mapping, to understand what are the targets that gives us the most benefit with the least risk. And it's probably going to be a combination of a single-shot devices for first times, and I guess focal large tip or different solutions, but focal mapping and ablation for redos. That's my gut feeling.
Yes, and I think this is particularly also important because still it will and should go to a tailored approach, right? So it's of course always easy to apply big lesion sets in everybody, but I think the challenge is to identify those patients who actually do not require such intense and just extended ablations in general.
That's true. You know, even in the persistent AF study done with the Farah system, you could see that, as Melanie mentioned before, the physicians were not asked to do anything more than PVI, but the majority of them did. They did isolate the posterior wall, they did make mitral lines and roof lines, and you know what? This patient did really well. Like with robust monitoring, their outcome was like around 75%, which is good for today persistent AF. Now, whether this is due to the lines, in some degree of analysis, it didn't show that that was the case, but I think, you know, that needs to be explored more. And I think the other interesting part when you mention point by point is we know that Maze procedure worked. It worked for many, many years. So now with catheters that can achieve designed lines that are durable, a maze-like, percutaneous maze-like ablation procedure, not sure that that's like what we sit here and we desire to do, but it could be a percutaneous solution that leads to improved outcome. I think that needs to be explored as well.
Perfect. So thank you very much, Melanie. Thank you very much, Elad, for this interview. So this was Heart Rhythm TV here from APHRS in Sydney. And, well, let's just enjoy the rest of the conference.